Plus, our topic for today is on oroantal fistula. So what is an oroantal communication? An oroantal communication is an unnatural perforation between the oral cavity and the maxillary sinus. When does this become a fistula? So once this communication gets lined by epithelium, then it becomes a oroantal fistula. And a fistulous tract, which is present more than 14 days, it should be considered as a chronic fistula. Coming to a brief of the anatomy of the maxillary sinus. The maxillary sinus is the largest of the paranasal sinuses, and it is roughly pyramidal in shape. It may be asymmetric on either sides. It has a base, an apex, and 4 walls. The base is formed by the lateral wall of the nose, and the apex is formed by the zygomatic process of the maxilla. The roof is formed by the floor of the orbit, and the floor is formed by the alveolar process containing teeth from the premolars till the third molars. Now, the sinus, it drains into the posterior hiatus semilunaris of the middle meatus. The ostium is 3 to 4 mm high on the posterior end of the nasal wall. The blood supply is by small arteries from the facial, maxillary, infraorbital, and greater palatine vessels. Lymphatic drainage is into the submandibular glands. And the nerve supply is by the anterior, middle, and the posterior alveolar nerves, which are branches of the maxillary division of the trigeminal nerve. Now, the sinus at birth is usually higher in position, and it is very small, and it grows by a process known as nematization. So it is after the eruption of all the teeth, this attains its position as it is now, the fully grown sinus. And what are the functions of the maxillary sinus? It, of course, lightens the skull. It warms and moistens air that is inspired, and it gives resonance to the voice. This is a various blood supply to the maxillary sinus. Coming to the etiology, etiology can be due to extraction of teeth. Now, while extracting a tooth, if you're going to force a root bit into the sinus, then that can cause a communication. If there's going to be any kind of a periapical infection of the tooth and the sinus wall or the floor has been destructed, in that case also you can have a oroantal communication. Due to certain surgeries like a cyst removal surgery, that can cause a oroantal communication. Facial trauma, malignant tumors of the area, syphilis, and osteomyelitis. Coming to the pathogenesis. So once there's a penetration into the antrum, be it any cause, what happens is there's usually the formation of a blood clot, which occludes the oral end of the perforation. So this undergoes organization and healing takes place uneventfully. Now, in case there is a periapical infection or infection in the maxillary sinus, what happens is that the clot usually gets infected and disintegration of the clot takes place, as a result of which the persistent communication gets epithelialized and there's a fistula formation. So it is actually the fate of the clot which decides the formation of a communication. Coming to the symptoms of a fresh oroantal communication. Remember 5 E's. You have escape of fluid from the mouth to the nose when the patient gargles or rinses the mouth following a tooth extraction. So this is known as nasal regurgitation. That is where the patient, either while gargling the mouth, there's escape of fluid from the nose. Epistaxis, which may or may not be associated with frothing at the nostrils. Then you have escape of air on sucking, inhaling, or puffing the cheek. That is, the patient will be unable to blow. Enhanced column of air causing an alteration in the vocal resonance. That is, usually you have patients with a nasal twang when they have a oroantal communication. Excruciating pain in and around the affected sinus, tenderness over the cheek. And the classic symptom what the patient usually will tell you is about the escape of fluid when the patient is trying to gargle the mouth. Coming to symptoms of a established oroantral fistula, you have pain, which is of dull aching in nature in and around the antrum, earache, frontal and parietal headaches. You have persistent, purulent, foul unilateral nasal discharge. You have unilateral fetid odor and taste. There's postnasal drip. There's nocturnal cough, which causes hoarseness of the voice and catarrhal deafness. You have fever in severe cases. There is an anosmia and popping out of the antral polyp is seen, which is usually seen as a bluish red lump extruding from the fistula. Coming to diagnosis, diagnosis can be done by doing a nose blowing test where the nose is pinched and the patient is asked to blow, and you can see here a whistling noise or escape of air through the mouth. Or you can ask the patient to rinse the mouth and you can see escape of fluid from the nose. You can also take intraoral periapical radiographs with a silver cone or maxillary sinus radiographs with or without a probe. So these are all methods by which you can understand the presence of a communication. You can also do the mirror fogging test by placing a mouth mirror into the area of the fistula. You can see fogging of the mouth mirror because of the escape of air. You can also see if a cotton is held in the region of the fistula, you can see deflection of the cotton because of the escape of air. Now coming to management, what is the purpose of management? The purpose of management is to protect the sinus from the oral microbial flora and to prevent escape of fluids and other contents across the communication, to eliminate existing antral pathology, and to establish drainage through the inferior meatus. Coming to treatment, treatment can be divided as early management and late management. In the early management, there is immediate surgery to achieve primary closure. So this is done by reducing the buccal and the palatal alveolar bone so that you can get a closure of the buccal and the palatal flaps. Now, simultaneously, you'll have to put the patient on antibiotics to prevent any kind of sinus infection. You can prescribe the patient analgesics for the pain, put the patient on nasal decongestants. And also, you can also give the patient obturators so as to prevent entry of the oral fluids into the sinus. Now, coming to the treatment of chronic oroantral fistula, this can be done using an operation known as the Cadwell-Luke operation, which is a recommended surgery in cases of chronic maxillary fistula, and it is indicated for the removal of inflammatory tissue and sinus mucosa when irreversibly damaged by the infection. It is also a technique that is used for retrieve foreign bodies within the sinus. This can be a root tip or a dislodged implant or anything for that matter. So this is a procedure where an incision or a semilunar incision is placed from the region of the canine fossa to the molars. You open up a flap, you see the anterior wall of the sinus. A small opening is made into the anterior wall of the sinus in order to get an access into the sinus. So this can be used to retrieve any foreign objects in the sinus, and it can also be used to remove the chronically infected sinus mucosa. Coming to local flap procedures, the most commonly used flap procedure would be a buccal flap. So any small defect can be closed using the buccal flap. There are two types of buccal flaps here. You have the advancement flap and you have the sliding flap. The sliding flap is called as a trapezoidal sliding buccal flap, which is put forward by Moxer. Now, the disadvantage of this is that there is a loss of area which has to heal secondarily. So if you look at the picture, you can see that a trapezoidal flap is raised with the periosteum and it is repositioned in such a way so as to close the defect. And there's a region in the anterior area which has to heal secondarily. Another disadvantage here is that large amount of gingival attachment needs to be needed to facilitate the shift. Now, the advancement flap is the buccal advancement flap was put forward by von Reherman in the year 1936. And in this flap, you can see that there are two diverging incisions that are placed, and a full thickness flap is raised along with the periosteum. Now, because this is a very the periosteum is going to be inelastic, what is done is the periosteum is scored and it is made to advance over the defect. So these are just few photographs, clinical photographs of how it has been done by advancing the buccal flap. So two diverging incisions, the periosteum is scored and made to so as to lengthen the flap and close the defect. The advantages of this is that it provides a broad base for good blood supply. There is no denuded area which has to be left for secondary healing. And then the flap allows a simultaneous Calvin loop procedure to be performed either directly or through a small incision extended anteriorly from the base of the flap into the region of the canine fossa. The major disadvantage here is that there's going to be a reduction in the depth of the buccal vestibule. So the question of placing a denture for the patient, the future possibility of a denture for this patient is a little questionable. This is just few case reports of how the fistula was managed. First, an obturator is given. Once this has gone into a chronic sinus, the epithelium around the sinus, the epithelium around the communication or the fistula is removed, and the buccal advancement flap was done here, where two divergent incisions were placed, the periosteum scored and made to advance over the defect. Coming to palatal flaps. Palatal flaps are based on the greater palatal vessel, and it was first described by Ashley. There are different types of flaps. You have a straight advancement flap, the rotational advancement flap, the hinge flap, and the island flap. The advantages here is that it has ensured vascularity, good thickness of the tissue which resembles the attached sclera. But the disadvantage here is that the need for rotation, which can risk the blood supply to the area, and also you have a raw surface which is left for secondary healing. So you can see here how the palatal flap is based on the length of the defect, and it is made to rotate and close over the area of the fistula. Once the fistula's lining has been, the epithelial lining. You have a secondary area here which should be healing secondarily. The rotation advancement flap, the operation technique is that either taking the incisive branch of the nasal container or the palatine this practice exercise, and the flap is made to rotate over the sum body. You have a secondary area for area which is left for secondary. Coming to palatal island flap, which is described by Henderson, which is used to close large defects. Here, what is done is that a submucosal flap is taken. So one part of the flap is used to close the fistula, and the other part of the flap is used to close the raw area. So there is no secondary, there's no raw area which is left behind for secondary healing. So one part of the flap goes into the defect, and the submucosal flap goes into the defect, and the other part of the flap goes to close the raw area of the lower side. Hinge flap. The hinge flap, the mucoperiosteum on the palatal aspect of the OROANTAL fistula can be used as a hinge flap to close small openings. So it has minimal blood supply. That is why the size of the flap must be limited. When you have small defects, this can be used. Combined local flaps. This uses simple transverse bipenetrant buccal flaps, and this has minimal mobility. So you can use a combination of the buccal and the palpal flaps. When you have double layer closures, here there is double overlapping flaps that are used. The use of two donor sites results in increased surgical time and larger delivery rate. So you can see that in one side the buccal part of fat has been used, and also the other end you have the palpal flap, which is made to close over. That is giving a double layered closure. This is found to be very effective and beneficial. Coming to other regional flaps. Regional flaps are tongue flap, temporalis flap, and buccal flap. The tongue flap was introduced for intraoral reconstruction by Lexa, and it has excellent blood supply, which is a pliable flap, and the ability to achieve primary closure of the donor site makes it a very versatile flap. The tongue flap can be either anteriorly or posteriorly based, and there's also lateral flaps, which is more easier for closure of the oral because of its proximity to the location of the fistula. Here you can see anteriorly based flaps and lateral flaps, which are used for the closure of the coming to temporalis muscle flap. Here, because of the proximity to the oral cavity and safety of the vascular pedicle, it is also pliable and minimal functional aesthetics is there. So because of this, you can use this flap for the closure of larger defects. You can see that the temporalis muscle is made to slide down underneath the zygomatic arch and is used for the closure of larger defects. You have the buccal flap. The buccal flap, because of its close proximity to the site of defect and ready accessibility, also excellent blood supply. It has been used for the closure of the fistula. Now, since this is easily available, and just by placing a horizontal incision in the third molar region, you can ease out the fat and can be used for closure. Now, this it usually becomes epithelialized within 2 to 3 weeks after placement. Bone grafts. The problem with bone grafts is that you require second surgical procedures, and the disadvantage here is the risk of exposure of the bone graft on the ankle side that can result in infection, loss of the graft, and persistence of the fistula. We also use other plastic materials for the graft, which is gold foil, tantalum, polyethylene, methacrylate, lyophilized porcine, hydroxyapatite block, and recent advances in the use of allo transplants of the facial lateral and angular matter. You have the vaccinator myomucosal island flap, where an incision in the cheek is done, and you take the vaccinator muscle out in order to close the defect in the palate. So another technique that is more newer is the use of interseptal RDC, which is the Leeds technique of introseptic surgery, where the interseptal RDC is used to close the OROANTAL fistula. So here what is done is that a mid-festal incision is placed, and with minimal deflection, tunneling of the buccal and the palpal flap is done. After removal of the intermedullary septal bone, the buccal and the palatal cortices are made to fracture, causing a broomstick fracture, and thereby the flap of the buccal and the palpal aspects can be approximated. This is a still technique that has been followed. So with that, we've come to the end of today's topic. So thank you.